We know that we have to know what to treat first of all. Usually, according to the previous studies, the early treatment ROPs and the cryo group, we end up by the definition that we have to treat the patient when he is at the threshold ROP or a high risk pre-threshold, or what we call it type 1 ROP. And Dr. Saad, I think, and my colleagues, they already clarified those definitions of threshold and the high risk threshold or the type 1 threshold. When to treat, as Dr. Saad mentioned, that in the aggressive posterior ROP, it should be within 48 hours. And other than that, the treatment should be addressed before the 72 hours time. Modalities of treatment is a cryotherapy, laser photocoagulation, anti-VEGF, and surgical. Cryotherapy, it's almost abandoned nowadays, but in a place where you cannot have a laser machine and you don't have things except cryo, then you have to apply that one. And أنا ماني عارف. دخل الفم يا جماعة. خلاص أنا أشيل لك هو كده. طيب. أنا آسف. Of course, the laser treatment, it's the established and well recognized and used all over the world, and it has a long history of effectiveness and safety. Anti-VEGF, it started a few years back, and still just only one trial has been not approved, published by the beta ROP. So in laser, we usually address the laser in the area of avascular zone here, and this is the place where we address the cryo or laser. It is only in the avascular zone. So this is the machine, as Dr. Saad mentioned. It should be diode. If you don't have a diode, then maybe the green laser can be used, and this is the cryo. But we have to be careful about things, the dilating drops. Maybe the most available dilating drops, phenylephrine, is 2.5, but if you do have the one which is 1.25%, I think it's better, because the lower the concentration we are using for the those babies, the better will be the for them, and with less complications. Both manipulation of the eyes and the drops used to dilate the pupil can produce systemic sequelae, most notably bradycardia and cardiac arrhythmias. But in cryo and laser management, we have to do this either in the ICU or in OR. There are some group in India now. They are capable of doing this one in ICU without even sedation by topical drops. Of course, we need intubation and sedation and topical anesthesia with oral sedation. As I mentioned, it has been tried in India. So talking about treatment, cryo carries some side effects like conjunctival chemosis, anterior and posterior inflammation, serous retinal detachment, and macular scar. Of course, because sometimes when you apply cryo, the cryo expand. It might go out of your visual field. That's why you have to be careful. Sometimes even if you cannot see the spots of the cryo, you have to know the effect, and you have to stop within seconds. So you have to put a plan for yourself for after how long I will stop, because the cryo spots will expand, and it might go beyond your visualization. Laser side effect, development of cataract. It is less with diode more than with argon, but it is not visually insignificant. It can cause angle closure glaucoma, which is rare, and usually it is seen 2 to 5 weeks after treatment. So you have to be careful following the patient after treatment. One of the things that you have to do is checking the IOP. Most of the physicians, they are not checking the IOP, so these babies, they might be missed if their IOP is a little bit high. Foveal damage, maybe it might be happen with the unexpert physician, and of course the debate of the peripheral field defect. So this is a small comparison between the cryo and laser. We can see that both of them, they are proven to be effective. The cost maybe in the cryo group is a little bit low. Availability, usually both of them nowadays, especially the laser, they are available in every hospital, not in every hospital, in the hospital where the ROP screening or ROP treatment modality is carried on. Pain, it is more painful in the cryo group with more bradycardia in this group as well. Anesthesia, both of them, they need anesthesia. The easiness of reaching the posterior pole is more with the laser, and post-op swelling of lid and conch is more with the cryo group. Exudative detachment, possibly with a heavy treatment in the cryo group, and the treatment duration in the cryo group, it's diffuse and shorter, whereas in the laser group it is precise and longer. So those are pictures after the laser, and as Dr. Saad mentioned, we have to do a confluent laser and in the anterior to the ridge or in the avascular area, and this is just only a scheme showing that the indirect and the the cryo probe. So after treatment, how can you follow those patients? Examination should be carried every 1 to 2 weeks for 1 to 2 months. Then at least the frequency of the examination will be less depending on the clinical course. Of course, as we mentioned before, that the infant, they are at high risk of developing myopia, stigmatism, anisometropia, strabismus, peripheral field defect, and reduction of night vision if he received a very heavy treatment in the periphery. And after termination of the examination, those patients should be referred to the pediatric ophthalmologist for to rule out all those side effects. Surgery. Surgery resulted in visual acuity or flat perception of better in 70% of the babies, and 22 to 300 or better in 30% of them. Usually retinal detachment develop in 14% of eye of ROP patient in comparison to the normal population, and it occurs by 6 to 12 weeks after delivery. As retinal detachment developed in 16% of type 1 retinopathy of prematurity. Retinal detachment is more in eyes with a vitreous hemorrhage. So we have two types of surgeries here. We have the scleral buckle and we have a vitrectomy. In scleral buckle, usually it is addressed for type 4 retinal detachment. What we used to put is the encircling band, but this is in case that we are having 360 or more than 2 quadrants of retinal detachment. But if we have a localized detachment, say it's in the temporal part, then we can use the segmental type of scleral buckle. Our objective to put the scleral buckle near to the ridge, and we make the height of the buckle moderate. Of course, when we do this procedure, the intraocular pressure will be increased, and the lens itself is going to be pushed forward. So paracentesis should be done, and in some surgeons they do drainage of the subretinal fluid. As I mentioned, by putting the band, the axial length of the eye will be increased, and then the patient will end up by myope. It is recommended that we have to remove the scleral buckle after we are making sure that the reattachment is occurred, or when there is an isometropia developed. Why we have to remove? Because the globe, it's not the globe itself, the eye itself, and the bones around the eye, they are stimulated in the growth by the eye itself. So when the development of the globe is restricted, we might expect the orbit will be smaller than the expected as well. So in pars-plana vitrectomy, what is the recommended one is the lens sparing vitrectomy, and it is usually for stage 4 and stage 5 ROP. This is a stage 5 ROP when we have retrolentan, as Dr. Saleh mentioned, retrolentan fibroplasia. This type, it is called funnel shape, closed anterior, closed posterior, and this is type 4 when we have only retinal detachment, subtotal retinal detachment, whether including involving the fovea or not involving the fovea. According to the series of study, reattachment was managed in the 82% of the patient in stage 4A, and capable of reattaching 70% in stage B, whereas in stage 5, only 14% of the patient capable of having reattached retina. In small series study, it showed that the lens sparing vitrectomy with scleral buckle is not superior to lens sparing vitrectomy alone. We have to be sure intraoperatively that we have to detach the posterior vitreous and not to have any break, because if you have any break here in the pediatric retina, it's a hell. The patient will have extensive PVR, and as they mentioned, you lose the game. Okay, thank you.